All right, we're going to do something just a little bit different today. Because there's a lot of information here that I wanted you to have. I want to emphasize the case studies, and most of it you can read on your own and look up the studies and read the studies that I have here for you. But let's get started, and then we're going to jump ahead to the treatment stuff. There's the disclaimer, and here are our objectives. We're going to talk about the nuances, or I have the nuances for you, the necessary laboratory testing, which is in here, and treatments, both non-pharmacological and pharmacological. And as you recall, our goal is to prevent cardiovascular events in those individuals at risk and in those individuals with subclinical vascular disease. And we also want to prevent secondary events in those individuals who've had a prior event. Last week, we reviewed the HPA axis and its role in cardiovascular events and mortality. We talked about glucose dysregulation and its effect on the endothelial glycocalyx and the endothelium. We talked about how hormone deficiencies increase potential for adverse cardiovascular outcomes and how menopausal hormone therapy and testosterone therapy likely improve cardiovascular outcomes. We also mentioned gut dysbiosis and a SAD diet, how they increase TMAO, an independent predictor. We mentioned autonomic nervous system imbalance and how it's associated with increased event rates. And one's inability to detoxify, which we're going to focus a little bit today on, increases inflammation. And I'm going to go through this very quickly, and then we're going to get to the bottom line. You want to do a day in the life of what a typical day looks like. You want to assess traditional risk factors and non-traditional risk factors. In addition, there are certain things we need to ask about. One is adverse pregnancy outcomes. Gestational diabetes, preeclampsia, eclampsia, and preterm deliveries are all associated with increased future heart disease risk. Chronic inflammatory disorders like autoimmune diseases. You should ask about autoimmune diseases in men, but they're much more common in women. Increase MI and CVD mortality risk 2 to 3-fold. And you know that steroids are often the first line of treatment, and as we are aware of, it increases metabolic syndrome and premature atherosclerosis. Osteopenia and osteoporosis is associated with cardiac events. Again, we should ask about this in men, but women are more prone to this. And remember, low vitamin D, which is more common in women, is associated with a 1.62 times increased cardiovascular event rate. But note, vitamin D doesn't decrease event rates. And then we talked a little bit about Takotsubo's cardiomyopathy, which is highly prevalent in postmenopausal women. It's associated with endothelial dysfunction, microvascular dysfunction in the absence of critical coronary disease. And these women have a higher cardiovascular morbidity and mortality when compared to their peers without Takotsubo's. Marital stress in women is associated with 3 times increased coronary event risk, despite controlling all other risk factors. And depression in women less than 55 is associated with increased cardiovascular mortality when compared to men. And vasomotor symptoms are linked to adverse cardiovascular risk factors. Here's a study by Rebecca Thurston, and this is a sub-study of the large SWAN study of women's health across the nation, and they looked to determine whether frequent and or persistent vasomotor symptoms were associated with the risk of increased non-fatal and fatal cardiovascular events. It was a longitudinal study over 20 years. Pre and early perimenopausal women were enrolled and they were followed. Vasomotor symptoms were categorized as none, 1 to 5 days every 2 weeks, and greater than or equal to 6 days every 2 weeks. And you see, remember, these were not done using LC-MS. It was done doing an immunoassay, and the estradiol levels are really not that much different. But what they found was that frequent or persistent vasomotor symptoms were associated with a 50 to 7% increased risk of future events. And you can see this here, years from, enrollment, and here's the CVD event rate. So they also determined that more studies are needed. So frequency and or persistent vasomotor symptoms are more than an annoyance. They are associated with increased cardiovascular events. And then Graham Jackson, in the early 2013 timeframe, said this: erectile dysfunction should be considered a vascular disease until proven otherwise. ED and cardiovascular disease share the same set of risk factors. ED is an independent risk marker. ED may indicate subclinical vascular disease in otherwise asymptomatic males, and it's not surprising that CVD patients are more likely to have ED, and patients with erectile dysfunction are more likely to develop cardiovascular disease. And interestingly, there's typically a 2 to 3 year time lag between ED onset and cardiovascular disease symptoms. That doesn't mean they don't have subclinical vascular disease. It just means they don't have overt cardiovascular disease. And the first cardiovascular disease may be sudden cardiac death. And as you can see here, ED severity is correlated with disease burden, and it has been independently associated with events. And this is a meta-analysis done by Zhao, where they looked at about 154,795 males in about 25 studies. And they set out to assess whether erectile dysfunction was an independent risk factor. And what they found was severe erectile dysfunction predicted higher cardiovascular disease and all-cause mortality. And when they compared to men without ED, men with ED had a statistically significant increase in cardiovascular disease by 43%, coronary disease by 59%, stroke by 34%, and all-cause mortality by 33%. And they concluded that CVD, coronary disease, stroke, and all-cause mortality may be significantly increased in men with ED, especially severe ED. So all men with erectile dysfunction should undergo cardiovascular risk stratification, regardless of their risk factor profile or cardiovascular symptoms. And here is the IEEF5 questionnaire that's been validated regarding erectile dysfunction. And every single male that you see in your practice should take one of these questionnaires. And you see as the numbers decrease, erectile dysfunction gets more severe. And you also want to think about low testosterone. And so you want to also have them do the ATOM questionnaire. And so when you look at the MESA study, this is a sub-study, they looked at the association between baseline subclinical vascular disease and subsequent development of ED. This is typically backwards, right? Typically, patients have ED and then we go searching. This was the first study to reveal that subclinical cardiovascular disease is an erectile dysfunction predictor and will determine the temporal relationship. This is 862 men. Their mean age was 60. At enrollment, they had no known CVD. They then went under a battery of vascular studies, coronary calcium, CIMT. They looked at endothelial dysfunction, vascular stiffness, ABIs, et cetera, et cetera. And what they found was that men who developed ED had a higher baseline prevalence of vascular abnormalities, except ABIs, when compared to men without erectile dysfunction. And coronary artery calcium and a carotid plaque score, that's carotid plaque burden, really, of how much plaque there is, was statistically significantly associated with subsequent ED. And you can just look here, the number of vascular abnormalities, this is the frequency of among patients with different vascular abnormalities of the presence of erectile dysfunction. And as vascular abnormalities increase, so does erectile dysfunction. The same here. And so they concluded that subclinical vascular disease is common in men who later develop ED. So in all males with erectile dysfunction, Proceed with cardiovascular risk stratification, regardless of symptoms, and in all men with subclinical vascular disease. Assess them for ED as well as low testosterone. Speaking of low testosterone, this is a small study, 5-year prospective study done in Italy, assessing cardiovascular disease in men with erectile dysfunction and testosterone deficiency. All of these men were at intermediate risk as defined by the Framingham 10-year event rate, and intermediate risk is 10 to 20%. 802 men, 40 to 80, and here they all had endothelial function, and they all had the erectile dysfunction questionnaire. And the bottom line is men whose total testosterone was less than 300 had a higher prevalence of all risk factors. In addition, they more frequently had acute myocardial infarctions, death post-MI, major stroke, and the composite of all major adverse cardiovascular outcomes. And you can see testosterone less than 300, testosterone greater than 300, and you see that independent predictors of future events were dyslipidemia, not surprising, that's an inflammatory marker. Lipids are part of the innate immune system. Obesity, inflammation. Total testosterone less than 300, and erectile dysfunction. So men with cardiovascular disease risk factors in ED should have total testosterone levels obtained, and testosterone therapy may prevent future events. So in males with ED, check hormone levels to assess the presence or absence of testosterone deficiency. And improving total testosterone levels may decrease major adverse cardiovascular events. And so a complete history provides insight and the need for additional risk stratification. In females, vasomotor symptoms are important and not just an annoyance. In males, erectile dysfunction is a marker of vascular disease. And we're going to skip ahead now so we can get to what everybody really wants to see. The physical exam, the laboratory data are pretty straightforward. I'm going to start with uncommon treatments that many of you may not be aware of, and that I use and that you should consider including in your armamentarium. Arterisol has recently been patented for vulnerable plaque stabilization and regression. It strengthens and heals the glycocalyx, thus ameliorating vascular dysfunction. Its main component is rhamnin sulfate, which is this green algae that I can't pronounce. And known functions of this green algae are antiviral, anticoagulant, anti-tumor. You could see all the things it does. It decreases blood sugar. And as we talked about last week, blood sugar or elevated fasting blood sugar, even for 15 or 20 minutes, causes damage to the endothelial glycocalyx. It's a powerful regenerating compound. In the setting of LPS-induced endothelial cell inflammation, it'll decrease tissue factor and von Willebrand's factor, thus decreasing procoagulation. And let me just show you, this is very interesting, not as an absolute, but this was a proof of concept study done with Arterisol, looking at its effect using fancy MRI scanning on vulnerable plaque, the lipid-rich necrotic core, which is kind of soft, and that's the stuff that's prone to rupture. And what they found was that it reduced this lipid-rich necrotic core by 47% in males and 64% in females. And you say, wow, but let's compare it to what statins do. And when they looked at statins, using the same parameters, MRI, carotid plaque regression, looking at the lipid-rich necrotic core, they found that statins only reduced the lipid-rich necrotic core by 25% and 38% in females. And so Arterisol in the short term led to a greater percent reduction in the lipid-rich necrotic core to vulnerable plaque than statins, thus better stabilizing vulnerable plaque. That doesn't mean you shouldn't use statins in the appropriate population. I'm just trying to show you the power of this nutraceutical. You all know about magnesium. Aged garlic is another nutraceutical that has over 750 clinical studies. It lowers blood pressure by about 16%. There are a number of studies, one done by Matt Butoff on plaque regression, and it did cause plaque regression in the aorta when it was given for 2 years. It supports blood vessel integrity. It prevents glycation, of which is how the elevated blood sugars, by creating advanced glycation end products, it increases inflammation and oxidative stress. It works on the microbiome and immune support. And this is something that I use a lot. It's sun fiber. It's a soluble fiber. It's got prebiotics, so it produces short-chain fatty acids. It supports the gut, the immune, the cardiovascular system, and estrogen metabolism. A 2017 review documented significantly reduced CVD and CVD mortality rates, reduces in the incidence of coronary disease and stroke. It's tasteless. You know, you can put it on in oatmeal. You can put it in a smoothie. And patients seem to tolerate it really well. And here are 2 things that I tend to use for the HPA axis. Again, I use a lot of the metabolic code products, and I use the metabolic code questionnaire. And QuiCom is if somebody has, you know, low dopamine and, you know, does a lot of stressful eating, and Adapt CNS I tend to use in people who I think have lots of oxidative stress. It's got cordyceps. You know, you can give it. It's a weak PDI5 inhibitor, and both of them support HPA axis balance. And if you are not able to prescribe or don't want to prescribe, you can try tea time. You can try Yohimbe. Citrulline works better than arginine at increasing nitric oxide. But again, none of these have been studied in cardiovascular outcome studies. So again, or bone mineral density studies. So it is, again, you can use it, but you have to take the entire patient into context. And for estrogen, progesterone balance, Professional Health Products makes this. It's similar to E2, but doesn't bind to the estrogen receptor. It may help support bone mineral density in a couple of studies. It has been found to be breast protective, and like anything else, it acts like a hormone, so you need to monitor hormones regularly. You all heard of Chase Tree. It works by raising progesterone, lowering E2. It blocks FSH and increases LH. So if somebody has low dopamine and they do all that stressful eating, or they have fatigue, this may be helpful if you don't want to use progesterone. But its effect on bone mineral density, where progesterone is really important, hasn't been studied. All right. Everybody take a deep breath, and we're here to where we want to be. Peter. These are actually real patients. Peter's a 50-year-old lawyer who has not been working, who has been working from home since the pandemic. I changed his name, and actually I was going to call him Fritz, and I was going to call the female patient Brenda Lee, which people who know me know that I'm like obsessed with The Closer and Major Crimes, but I thought I would be chuckling too much, and I got to be serious. Anyway, he states that he can't concentrate, his work performance has decreased, and he has a foggy brain all the time. He's here because his spouse insisted. He has had 6 to 9 months of decreased libido, erectile dysfunction, reduced spontaneous and sex-related erections, and decreased orgasmic function. So this guy, regardless of anything else, needs cardiovascular risk stratification in addition to assessing all his hormone stuff. Prior to 9 months, he noticed decreased morning erections, which he thought was normal, but was without any other sexual symptoms. He sleeps 6 to 7 hours each night, such that he can wake up at 0400 to exercise for 2 hours a day. He does Ironman every day with no days off. So he over-exercises. Think about what his HPA axis is going to look like. He survives on coffee all day, otherwise he could not keep up. His diet is on and off, lately mostly off. When on, he eats a Mediterranean-style diet that is gluten and dairy-free. His diet lately consists of 1 to 2 meals a day, processed foods, lots of carbs, few vegetables, and a lot of animal protein. His cardiovascular risk factors are down here. He takes no meds. He has no allergies. He had a vasectomy at 45. His dad had first MI at 45 and his ApoE34. His older brother had a first MI at 50 and is also ApoE34. So not much lucky with the genetics. He's happily married for 25 years. He has 3 grown healthy children. He drinks red wine with dinner on weekends. He never smoked. His review of systems is remarkable for irritable bowel, and he's noted testicular shrinkage over the past 6 months. So you need to ask about these things. His blood pressure is high, and he says it's similar to what he gets at home. His heart rate was 90, and he says normally his heart rate's about 60 or 50. So this may just because he's nervous. He's 6 foot tall, 190 pounds. His BMI is 25.8, barely overweight. His waist to hip ratio is 1.3 to 1. You want it to be less than 0.9. Around or 1. His JVP is normal. His cardiovascular exam has an S4, which is a filling sound indicative of a stiff ventricle. His pulses were all symmetrical. His testicular and rectal exams were normal. He scored an 8 on the ADAM. That should have been on the IEEF, not the ADAM. And he was low on the ADAM score. He's a 50-year-old male, asymptomatic with cardiovascular risk factor and sexual symptoms. There's him summarized. He probably has HPA axis dysfunction. He probably has testosterone deficiency, and he has dysbiosis with metabolic endotoxemia. How do I know that? You'll see when his labs come. Here's what I do on just about everybody who comes to me for preventive cardiology and basically for hormones, and I do some of this depending on the history. And everybody gets a Dutch test, and I have to tell you that previously I may have used serum and occasionally saliva for cortisol, but knowing what I know now, and what I've learned from, Mark Newman and the clinical team over the past 2+ years and my own research, I cannot take care of a patient without doing a Dutch test. It tells me about metabolomics. It tells me what the tissues are seeing. It gives me insights into not just the free cortisol pattern, but total cortisol production and how it's being activated and inactivated. And, in some guys, in a guy like this, I will get a testicular ultrasound. And very interesting, his fasting blood sugar was 100, his fasting insulin was 10, 5 to 7, and his hemoglobin A1C is 5.9, so he's insulin resistant. His vitamin D was 30. His TSH was 1, his T4 was 1.5, his T3 was 3.2, not terrible. His reverse T3 was 12, but he's got thyroid antibodies, and that's why I know he has dysbiosis with metabolic endotoxemia. His C-reactive protein is 2.5, his homocysteine is 10, his TMAO is 8. And his ADMA is 125, which is an independent predictor. So he's got a bunch of moderate and high risk markers. His triglycerides were 180, little too high for me. I like them closer to 100. His LDL particle number is 1300, which is moderate risk. His LDL particle number is 5,000. You want it much higher than that. And I will tell you that his HDL was 35. His ApoB is moderate risk. He is lucky. He's an ApoE33. He got the 3 from his dad and the 3 from his mom. And he's got an abnormal CIMT, carotid intermedial thickness. So he's got subclinical vascular disease. And here are his hormone levels. His total testosterone was 225. His free T was 55. equivalent using equilibrium dialysis, and I also calculated it. His E2 was 18, which is lower than you want. So he may be at increased risk for osteopenia. You need an estradiol in a man. They say above 10 to 15 to maintain bone mineral density. I like it above 20 and less than 40. That's where I keep my guys, somewhere in the 30 to 35 range, and you must use LCMS/MS, similar to what you must use for testosterone in all women and for postmenopausal women when you're measuring estradiol. His serum hormone binding globulin is 13. Why is that? Well, he's insulin resistant. Normally, when individuals are insulin resistant, serum hormone binding globulin goes down. His LH is 5, and he had a testicular ultrasound, which was 8 mils squared, and the range is 12 to 19. So it's decreased. His testicular volume is decreased. So do we need additional cardiovascular testing? We know he has subclinical vascular disease, but do we need anything more? Well, this is a decision tree that I adapted from Martin Miner and Gandaglia, and it has to do with erectile dysfunction in males. So he has confirmed ED, he doesn't have cardiovascular symptoms, and what is his cardiovascular risk? And depending on his risk, you're going to do a coronary artery calcium scan, and you want to test his exercise capacity if it's appropriate. And so let's see. Here's his, you can just go online. This is free, the ACC AHA CVD risk calculator. And as you see, his risk is 25.4%, whereas the 10-year risk for someone of the same age with optimum risk factors is 2.1. So his risk is high. So he was referred to a cardiologist, which is me, and I did a coronary artery calcium scan, and he has coronary artery calcium score of 80. And we did a Bruce protocol treadmill stress test where he exercised 12 minutes, achieved 100% of his max heart rate. He had no EKG changes. His resting heart rate at that time was 50, and he had excellent heart rate recovery time. And his HRV for a 50-year-old was excellent. And so he is going to need aggressive risk factor modification, statins. He's got subclinical vascular disease, arterisol, aspirin, and we did all that. And he also is going to get aged garlic. Now let's look at his hormones. Well, this is a Dutch plus, and let me orient you. The stars in between the two stars of the reference range. And so as you see in him, not only is his testosterone low, but his estradiol is really low, which suggests that this is a true number. Because all of a male's estradiol comes from testosterone. And if his estradiol was in here, you'd have to question this. Now we look at his salivary cortisol. And his morning, when he woke up, cortisol, if he did the test right, is a little on the high side. And his CAR is a little on the low side, 1.81. It's just above the bottom limits of normal, but it's certainly not optimum. And then his cortisol drops. But when we come over here, he's making adequate cortisol. His free cortisol is okay. His total DHES, which is all of this, looks okay. And if we stopped here, we'd be missing a lot. All right, let's look at his HPA axis. And the first thing I do when I look at this is I glance around at everything. And then I look at metabolized cortisol. This is me. Everybody has a different way of doing this. I look at both curves. And a good friend of mine and colleague who's very smart, Dr. Rice, who's the clinic and education director, and I were chatting, and she and I agreed that in order for you to get high cortisone, it must have been cortisol at some point, right? Because cortisol gets inactivated to cortisone. That's the only way this is going to happen. And you see his cortisone is much higher than his total cortisol. So he's favoring 11 beta HSD2 metabolism to deactivate that. And why would he be trying to deactivate cortisol? He's inflamed, he's insulin resistant, he's got a lot of oxidized stress, and though he's making a lot of cortisol, his body says, stop, I can't use this cortisol. I'm already inflamed. I probably have some degree of neuroinflammation. And to keep up with my needs, I need to deactivate this. And when we look at his melatonin, it's low, and melatonin is one of the body's most potent intracellular, and it's the body's most potent extracellular antioxidant. Glutathione is the body's most potent intracellular antioxidant. Let's look at, before we get to his organic acids, we've already looked at total DHEA production. Let's look at metabolized cortisol. And you see metabolized cortisol is favoring cortisol. So he's metabolizing cortisol predominantly in the liver, and it's being more of cortisol is being metabolized. All right, and now let's look at the glutathione markers. It's on the low end, not surprising. Melatonin is low, and he has a significant amount of oxidative stress. And if you just took this at face value and didn't see this, my guess is this guy's cortisol is actually at one point was higher than this, and the body is trying to deactivate it. And when we look at his androgens, what we see is his testosterone's low. Let's come here. His DHT is low. His 5-beta androsterone, androstenediol is low, as is his 5-alpha. He does not have a UGT SNP. And so, in essence, his testosterones are indeed all low. When you look at DHEA and DHEAS, remember DHEAS is adrenal it's made in the adrenal cortex. So similarly, it's not putting out a lot. And so he is further along on the HPA axis spectrum than you may actually guess from his just looking at a salivary cortisol. You wouldn't think it was so bad. And his resilience is not optimum. And then when we look at his metabolites, you see that he's making DHEA. He's just not sulfating DHEA, again, adrenal cortex. And this all happens as a result of the brain sending the signal to the adrenal cortex to make cortisol and DHEA and DHEAS. All right. Now let's look at his estrogen metabolism. Now, if I didn't have labs that told me his HSCRP was abnormal and his lipids were abnormal and his homocysteine was abnormal, if I looked at this, I would say this guy's inflamed. Even though his hormones are low, you know that based on his HPA axis, but here's more evidence. I'm guessing that aromatase upregulation would suggest inflammation. And, you know, I don't know if his estradiol may actually be higher if it wasn't being metabolized and his estrone wasn't being metabolized with upregulation of all the CYP1 enzymes. But inflammation is associated with aromatase upregulation, as it is 5-alpha and 5-alpha reductase. But look at here, look at all his, given how low his hormones are, you would have expected his metabolites to be really low, but they're not. They are actually fairly balanced, and he's methylating fairly well. But this tells me he is very inflamed. And so if you're going to talk about treatments, you know, this is just a general guideline for adaptogens, but remember to treat them not like, you know, candy or supplements over the counter. treat them as medicine. Start low and go slow. And when you're going to assess what you should treat a guy who's got low testosterone like he does, the first thing you have to ask is, what is his LH? Now, his LH was 5. It wasn't high, which would suggest primary hypogonadism. And he's had kids. Typically, this diagnosis is made at a younger age. And so he has some degree of secondary or mixed hypogonadism. And so you want to do restful sleep. You want a higher protein Mediterranean eating. You can try all this, tea time, or he certainly may need zinc. He's 50 years old. So you may want to go right to testosterone. He may not want testosterone. And so all of these are options. You also want to assess his prolactin, because if it's greater than 18, that may, in and of itself, that will suppress testosterone. And so he would need a workup. And don't forget that, especially in younger men, check for heavy metals and biotoxin illness. And when you're talking about testosterone options in a guy, you can use a patch, you can use a gel. Nobody uses patches anymore because of skin irritation. You can use androgel. 50 milligrams is typically the starting dose. If you use compounded stuff, you may need a higher dose, and you want to rotate it. And you want to check labs on a regular basis, and those labs typically include a direct rectal exam. Some people do it at 1 month and 6 months, 1 month, 3 months, 6 months, and a year. Some people just do it at 1 month, at 3 months and 6 months, and then a year. But you at least should do it biannually and yearly, or yearly on people on testosterone. Injectables, let me tell you a little secret about propionate and anthate. You want to use an anthate in older men. You get less fluid retention. You want to break up the dose so you don't get the highs and lows. Cypionate for younger guys, and I'm talking about, this guy who's 50 could probably take cypionate. I'm talking about a guy who's 60, 65. You may want to consider an anthate. And pellets are a viable option, cost considerations. And patients want a lot, but they typically don't need as much as you think. And don't forget to check a PSA. Greater than 0.75 nanograms per mil is worrisome for prostate cancer. But remember, testosterone does not cause prostate cancer, just like estradiol does not cause breast cancer. And here is what I gave him, because I think he has a lot of oxidative stress. I gave him Adapt CNS with its weak PDE5 inhibitor, chelated magnesium. I asked him to get IV therapy. I started a melatonin troche. It's a great anti-inflammatory, antioxidant, and it will help him with sleep, and this will be titrated up. And there's all the stuff for his cardiovascular system. It's all the stuff we talked about. Hormones, I started testosterone gel, 50 milligrams a day. I will convert him to pellets once I see how he does. And remember that for every 75 milligram pellet, you're going to increase a guy's testosterone to by 75 nanograms per deciliter. And you're shooting for greater than 500 to less than 1,000 in that, greater than 500 to 800 range. He's going to get vitamin D. He's got thyroid antibodies. So he's going to get naltrexone. He's inflamed. We need immune modulators and SPMs and probiotics and a Mediterranean diet. Now let's talk about Maggie. She's a 48-year-old perimenopausal female who seeks advice on menopausal hormone therapy. Her last cycle was about 8 to 9 months ago, and she's miserable. She's had brain fog, hot flashes, night sweats, and vaginal dryness for 9 to 10 months. No energy, feels anxious. Her mind can't stop racing. She has trouble sleeping, waking multiple times. In addition, she feels her heart racing all the time. She's happily married, has grown children. She's a physician, very busy practice, normal body weight and BMI. That doesn't mean she doesn't have visceral adiposity. She too is an over-exerciser. She recently had a diagnosis of osteopenia. So we have a couple of things increasing her cardiovascular risk, but this is very concerning that a 48-year-old has osteopenia. She eats a paleo diet with organic grass-fed beef, wild-caught fish, organic free-range chicken. She drinks no alcohol. She doesn't smoke. She eats lots of vegetables, doesn't eat any carbohydrates. She's on lisinopril, a multivitamin, vitamin D, methylated B vitamins, and she gets IV therapy monthly with 2 grams of glutathione. Her past medical history: she has hypertension, insulin resistance, borderline hyperlipidemia, that should be osteopenia. She had a recent mammogram and gyne exam, including a pap smear that was normal. She had gestational diabetes and preeclampsia with both children. So she has lots of high-risk indicators. She has a positive family history. Her mom had an MI at 45, her dad had an MI at 40, and her brother had an MI at 44. Her mom and dad are both ApoE34. Her brother is ApoE44. Mom and sister are breast cancer survivors. Some family history. Night sweats occur multiple times a day, every day. She has irritable bowel with constipation. Her blood pressure on lisinopril is 138/85. Her heart rate is 95. She's 5'6". Weight is 120. BMI is 19.4. She has a pretty optimum waist-to-hip ratio. The rest of her exam was normal, except she too had an S4. She had an ECG with prominent voltage. She had an exercise echo that came to me, which was normal. She's MTHFR positive. She's heterozygous for the C677T allele, which again can increase her risk of vascular disease. She's an ApoE34 and she's BRCA negative. So we have a 50-year-old symptomatic perimenopausal female. You see all her symptoms here. She probably has HPA axis and autonomic dysfunction. Somebody who runs that much shouldn't feel tachycardic all the time. She is perimenopausal. She's late perimenopausal. She has dysbiosis with metabolic endotoxemia. There's her EKG just to show you. She has voltage criteria for LVH. If her AVL, if this R wave was 11, she would definitely have ECG criteria for LVH. This is just voltage, which a lot of people have. Her glycemic parameters: she's insulin resistant. Her vitamin D is 70 while she's on vitamin D. And look at her thyroid: 0.9, 0.9, 2.7, 18, and her TPO antibodies are 100. When you see this thyroid pattern, and unfortunately I don't have time to talk about thyroid adaptation with HPA axis dysfunction, this is HPA axis dysfunction. This is down regulation. What happens is the thyroid is an organ that requires energy, lots of energy. And if it sees it doesn't have enough reserve, it will downregulate, and you'll see these kinds of numbers. Doesn't mean you shouldn't treat it, but don't keep bumping up your thyroid doses, because you'll drop TSH to almost 0 with no effect here and here unless you address the HPA axis. And again, her risk markers were elevated. Her advanced lipid profile was a little worse in some parts and a little better than Peter's. She's an ApoE33, and she does not have carotid intermedial thickness. So do we need additional tests on her? Well, again, here's our same thing, and I just put confirmed frequent or persistent vasomotor symptoms with no overt symptoms. Calculate the 10-year risk. Is she low risk, borderline risk, intermediate risk, or high risk? And then go from there. So that's what I did. And I just put her in the ACCHA risk calculator. And as you see, her 10-year risk of atherosclerosis is really low. It's higher than her peers, but lower. And then there are risk-enhancing factors, because this doesn't take into vasomotor symptoms, and on guys, erectile dysfunction. It doesn't take into account premature menopause or adverse pregnancy outcomes or any of the risk markers that we've identified. So she has a family history. She has a history of pregnancy-associated conditions. She has abnormal lipid markers. She's got elevated C-reactive protein. and all of the rest of this were normal. So they say 3 determinations, 1, 2, 3, 4. How much does this increase somebody's risk? Nobody knows. And I typically, if she would have had an abnormal CIMT, I would have put her in this intermediate risk. But, you know, this is me guessing. It's definitely, you know, somewhere in between here and here. So I called her a borderline risk. And so as far as I was concerned, she needs a coronary artery calcium scan. And it was 0. She had an exercise echo that she came to me with. She exercised 10 minutes, achieved greater than 100% of her max heart rate, and the echo was stone cold normal, no left ventricular hypertrophy. Her heart rate recovery time was 110 beats per minute. It needed to be less than 163. But her heart rate variability, as opposed to Peter's, which was 75, hers is 25. And that's because she has increased heart rate a lot of the time and doesn't sleep well. And so with a coronary artery calcium score of 0, but a borderline risk, lifestyle, if indicated, Reggie's Rice, CoQ10, Arterisol, and aged garlic, and we're going to look at her hormones. Now, she's perimenopausal. Do you need to do a Dutch plus on people who are, women who are perimenopausal, especially late perimenopausal? The answer is, I don't know. She hasn't had a cycle in about 9 months, but, or 8 months. I did it anyway, because I like to see what's going on. You know, I can better take care of patients when I have the entire picture. A one-day test doesn't give me an entire picture, right? A one-day test, if it was done on day 19, wouldn't have shown me these things, these little estrogen peaks, which we'll talk about in a second, and it would have told me that her progesterone is basically flatline, so she's in essence anovulatory. But I would have wondered if that was just, you know, if I missed, or it was going to happen much later. So I always do this. These estrogen surges in the follicular phase are called luteal out of phase estrogen bumps, and they're thought to be due to persistently elevated FSH and LH. And as you can see here, if she didn't have just a flat progesterone line, if she wasn't anovulatory, this is called change of life babies. This is how older women or perimenopausal women get pregnant, is they have these estrogen peaks, then they have, you know, progesterone peaks, and FSH and LH are high, and women get pregnant. Here are her serum labs, which were done around the same time. Her serum hormone binding globulin is low for 2 reasons. She's not making hormones, right? You need hormones to make serum hormone binding globulin, and she's insulin resistant. You know, 70, above 70, you start to see with menopause, but this is unreliable. It could be up, it could be down until she's actually menopausal. Same thing with LH. Her E2 using LCMSMS was 12. That's pretty low. And this was probably done around the follicular phase, because we were looking at testosterone, which you want to measure early in the follicular phase if you're using serum. And her total testosterone was 12, again using LCMSMS, and her progesterone was 0.1 using LCMSMS. And so they correlate. And now let's look at her Dutch complete, because you can't stop with the cycle map. You need to look at metabolomics, and you say, what the heck? Why is her estradiol high here? Because these were done around the same time, and they typically take the peak of estradiol and progesterone. And in her case, it was that luteal out of phase peak. And as you see, her testosterone's low, her progesterone's really low, and if you glance, this is urine, so you're not going to get a car. This looks pretty low, right? This is on the lowish side. This is definitely low. This is low. This is low, and this is flat. And as I told you last week, a flattened cortisol curve is associated with increased adverse cardiovascular events. And a low waking cortisol is associated with, now this is everything in her bladder, so I'm not sure that we can apply the MESA study, which looked at inflammatory markers, but everything in her bladder overnight, so she should have slept. And you see she's not making a lot of cortisol. Her total DHEA isn't very high, and when you add this up, it's not very high. So she is definitely further along on the HPA axis continuum. Now let's look at this. As opposed to Peter, who had really high cortisone here, this cortisol and cortisone pattern look similarly, which they should. This is what you want to see, this nice balance. When we look over at total DHEA, we already saw what it looked like before, and her metabolized cortisol is low, not surprisingly. And in the liver, she is metabolizing down. Cortisol is metabolizing by 5-beta reductase metabolism. And when we look, the only abnormality was the low end of the range of glutathione, which is not surprising. Her melatonin looks okay, but it's probably not okay enough. So we know she's inflamed just looking at this, and she's further along on that spectrum. You know, so her HPA axis, you know, she can't tolerate a lot. And so now let's look at her hormones. And remember, when you're looking at progesterone and metabolites, you're not looking at tissue metabolism, right? You're looking at pathway predominance. And here, because they're both so low, and you look here, alpha and beta, they're both low, but it looks like she has 5-beta pregnenolone preference. If we gave her oral progesterone, it'd be interesting to see whether that changed, because in the gut, the intestinal microbiome has 5-beta reductase, and the mucosal wall has 5-alpha reductase, and whichever one predominates may shift what you see in metabolites here. But one thing is clear, she has no progesterone. All right, now let's come over to here. Her DHEAS, again, which is from the adrenal cortex, is low, similar to her cortisol, so she is further along that continuum. Her testosterone is low, on the low side. How much of it is aromatizing, I don't know, but aromatase is upregulated in inflammation, and she is inflamed. Now, when we look at her 5-alpha, and everything's low, her 5-alpha and beta reductase, ethyl-calanolone is a little better than, so she's going down this 5-beta pathway. Androsterone is also a testosterone metabolite as well as a DHEA metabolite. But anyway, you slice the bread, it's on the lower side. Now let's look at her estrogen metabolism. Her E1 is high, her E2 is high, her E3 is on the lower side. And remember, adipose tissue or visceral adipose tissue has lots of aromatase. It should be converting cortisone to cortisol. It stores cortisol. It has a high amount of 11-beta HSD1 activity. But one of the reasons why it's not doing that is probably because this is, everything is downregulated, and her body is meeting, the cortisol is meeting the demands of her body. But when we look down here, once again, we see upregulation of all these enzymes and decreased detoxification. Similarly, Peter's detoxification was balanced, but he had upregulation of all these hormones. If we don't detoxify these hormones and get rid of these hormones, remember she had irritable bowel with constipation, these are all going to be toxic intermediaries 2-hydroxy will be. We know about 4-hydroxy, as will 16-hydroxy. So we know she's inflamed. She does have high methylation activity, but it may not be enough. This may outpace this, so we need to watch this carefully. And she does not have a UGT SNP. Women can get as well as men. Testosterone, 5-alpha is within, they're all at the lower end. 5-beta is within range. Epitestosterone is low. Typically, if she had a UGT SNP, this would be higher, as would be 5-alpha androstenediol, which they say is above range here a little bit. But in our data, it looks like that epitestosterone comes a lot from the ovaries. And so this is not surprising. So interesting to note. And she's metabolizing her androgens, 5-alpha, at least, which is upregulated in inflammation, testosterone to DHT to 5-alpha androstenediol is all upregulated due to inflammation. And again, you can look at treatments. And then if you are not really comfortable giving menopausal hormone therapy, you can use nutraceuticals and herbs and botanicals. But again, these do not improve bone mineral density, and I'm not really sure of I don't think there's a whole lot of evidence using these in cardiovascular risk. And for those of us who prescribe estradiol, the typical starting dose is 0.025 milligrams in a patch. Dose, the 0.014 milligram patch is no longer available. You want to place the patch on a fatty area, the abdomen or the butt. Just note that it increases absorption on the butt. You want to get labs in 12 weeks to assess. You want to give the body time to acclimate. Creams must be compounded, and remember, you may need a higher dose of a compounded cream to effectively reduce symptoms and come within the studied ranges. You know, menopausal hormone therapy focused on doses. In men, when they were giving hormone therapy, they focused on therapeutic ranges regardless of delivery. And I would tell you to do the same thing. In a young, in a perimenopausal or early postmenopausal, less than 5 years, you want to keep her estradiol 40, 60, and her Dutch, which, as I showed you, has been validated with serum about 1.8 to 2, and that'll give you that, 40 to 60 range. As women progress through menopause, they don't need as much estradiol, and you want to keep their estradiol levels less than 40, probably closer to 30. So just look at estradiol levels, which on a Dutch test is 0.7 to about 1.3. And remember that gels, which are FDA approved, they're not approved for osteoporosis. And I would not pellet women to start off with. I don't pellet women with uterus. I do pellet women without a uterus after I see how they handle transdermal estradiol, and I optimize their detoxification pathways, et cetera, et cetera. And don't forget, oral micronized progesterone balances these two effects, or vaginal micronized progesterone, not transdermal. Testosterone, the typical dose range is 0.5 to 5. In a perimenopausal woman, you want to start 1 to 3 milligrams. Menopause, 1 to 2 milligrams. Some people think you should start testosterone prior to E2 and give it with progesterone. If you're worried about a woman's endometrium, you may want to prime the endometrium so that it has progesterone on board so you don't get bleeding or spotting, and you want to monitor it. Vaginal, need lower doses. And so the most common is 0.5 to 1, and pellets are an excellent option. You need to understand metabolism and detoxification. And the most common doses are 75 to 125. Patients typically require, again, less than you think. And if you want to increase a woman's testosterone level, the same thing doesn't go for women and men, because if you said you wanted to decrease it by 75 and it starts off at 20, and that's what typically happens with a pellet, you get to around 100, 150. And so then here's her treatment plan. What I want you to notice, I didn't give her a statin. We did red yeast rice, which has statin properties, plus a whole lot of other good stuff in it, phytochemicals, and that's because she has no coronary artery calcium at all. Arterisol, aged garlic, CoQ10, sun fiber, fish oil, and curcumin for the inflammation. She got melatonin. She got a melatonin troche. Why did I give her that? She's got a family history of breast cancer. She's inflamed. Inflammation drives breast cancer as well as it drives cardiovascular disease. And what they have found in hormonally driven cancers, melatonin prevents certainly recurrence in women with breast cancer. And because she's so inflamed, I really need to get her antioxidant potential up. She's going to get 3 grams every other week. She goes once a month. She's going to start going every other week. And I started her on a patch, oral micronized progesterone, testosterone cream. She's going to maintain her vitamin D. And then I started her on just a little bit of thyroid, or you could give her something called thyroid complex, which supports the thyroid's production and synthesis of hormones. I'm going to start her on naltrexone, SPMs, and Moducare, probiotics, and a Mediterranean diet. And so the real question becomes, do you give people all this at once? Probably not. I start with the HPA Act. I start where they want to start. Most people want hormones, so that's a no-brainer. And then I kind of march through it, and I tell them for 3 to 6 months, this is what it's going to be, and then we'll reassess. And remember, CVD is a chronic inflammatory disease. HPA axis dysfunction, autonomic dysregulation, and hormone dysregulation increase cardiovascular event rates. Optimal hormone levels are necessary for cardiovascular health. Learn and understand hormone metabolism, metabolomics. It's essential for optimum health, whether you're talking about hormone health, cardiovascular health, gut health, all of it. Ask yourselves, are your decisions evidence-based, and are you questioning the absolutes and asking, show me the data? And remember that women and men may spend a third of their lives hormone insufficient, deficient, so it's really important that we get this right. And once again, there's our little monitoring BHRT, and red, yellow, and green is go, pause, and not the best test. And there are my chiclets, and don't forget that, and I ask you again, but why aren't you a provider? Become a provider. New providers receive 50% off, and I get no kickbacks from any of this, just so you know. I'm just telling you how I changed my practice with the use of the Dutch test. And you get up to 5 testing kits, and here are all your additional benefits, and the link is in the chat box. And I think that's it. We actually made it.
We made it. Thank you all again for joining us today. Don't forget to follow us on Instagram. Just search for the Dutch test. You'll find us. We will be announcing when the Q&A will be. So if you do have any additional questions that you would like Dr. Saltiel to answer, please send those to marketing@dutchtest.com. Again, marketing@dutchtest.com. Check your inboxes tomorrow for a link to the recording and to download the slides. I hope you guys have a great day, and we look forward to seeing you on next month's webinar. Information to come out soon about that. Have a great day.